I've always been interested in the fundamental parts of anything. I did some research in plants, and we were looking at the contribution of single cells to how the whole entire plant functions. And so what we're doing now in cancer is very much the same, looking at the very smallest contributing factors to cancer and trying to understand more about them and know what role they play in developing cancer. So we find these molecules which are called circular RNAs. These are sort of cancer Trojan horses, we describe them as, because they lie around people who didn't know about them for many years and then ignored them for even longer. And so similar to cancer relapse rates, which haven't changed really in the past 30 years, what we find is that these circular RNAs are much more abundant in patients who are treated for a cancer but then relapse or recur with another cancer. And so we've actually found that these are causative of these relapses. And so what we want to do is get rid of them and help tailor the therapies for people to reduce their burden. The cell is a very, very small thing, but in fact the circular RNAs are 10,000 times smaller than a cell. So they're actually quite difficult and not logical things to find. Initially by themselves, they don't cause any disease. However, in combination with a number of risk factors, they can actually develop into a cancer or other diseases. What we've found is that they're actually quite abundant and quite diverse. And so we have developed tests to screen for them and quantify them. And then from that information, we hope to feed that back to oncologists who can actually tailor personalised disease treatments. With any new technology, there's always some activation energy you need to leap over, some hurdles. And at the moment, what we need to do is convert our preliminary findings, our published findings, into a clinical setting. And once we've done that, we believe it'll simplify the translation of this to oncologists. That's our hope, and really the fact that that can lead back and benefit the individual who's often sometimes more informed about their specific disease than even some oncologists is only good information. Always helps disease prevention and disease treatment. It's what gets me up every day and happily bouncing into work. And it sounds terrible in a way that we get excited about cancer, but what I'd like people to understand is that we're excited because we have this groundbreaking discovery that can actually improve people's quality of life. So we deal with a lot of diseases, but primarily on leukemia and glioblastoma. Now, in no way are they more important than any other cancers, but they affect infants, they affect adults. And so, for instance, we have a patient that we have samples from who was born, had congenital cancer, then was treated and relapsed at 6 months of age, and then was treated again and relapsed at 1.5. So nobody can listen to that and have nothing but sympathy or empathy for that situation. And so those are the people, or at least the start of the people we would like to help treat. So we are on something very exciting, and it's my job, my duty, to actually translate that into the public space. But certainly this is something that can't be ignored. And for something to sit around for so long and be not investigated, as a local Adelaide boy discovering this and publishing a number of seminal papers in that area, it's important. It's a real success story. And so what we would like to do is to distribute this information, and that only comes with improved research funding, and so that's something we're looking to translate this to other diseases beyond leukemia, beyond glioblastoma, and so they should be as excited as I am. We've come a long way from early chemotherapies, which were designed to make the body so sick that the cancer couldn't grow anymore, didn't want to be there. And so now we've got more personalised treatments. So in combination with that, we hope the uptake of this screen that we've developed will be very rapid. Now, we can't propose, and we don't have a crystal ball to see going forward how long this will take, but certainly once we have that data translated into a clinical setting, we hope that will speed the process up. When we talk about personalised treatment, really what we're saying is if 1,000 people go into an oncologist with breast cancer, every single person will be slightly different. And so from that understanding, not everyone can receive the same treatment. The more we know about that cancer and the risk factors, if it's hereditary or if they're smokers, at the DNA level, the specific mutations, we can actually use some of the newer treatments to personalise that therapy down to Simon Conn with a certain cancer. And that's really what we would like to do with the circular RNAs, to use that as a sort of an add-on to inform more about how the treatment will work and give the patient confidence that once they're cured of this disease, that it really is a bona fide cure and not just giving you some time. And that's the real holy grail for me. So in many of the cases, certainly for breast cancer I can speak on, there's a 10% higher incidence of cancer for Indigenous Australians than non-Indigenous. Now, whether that's a genetic factor or whether that's also contributed to by the reduced screening ability or capacity is something to think of. And for my interests, I would love to see a more regular, routine MRI screen for people to be able to pick up early stage disease, which would alleviate a lot of health burden. There'd be an initial financial burden, of course, but I think that would be recovered in the long term. So if this could be done Australia-wide, including in these remote places, because everybody's important, nobody should be overlooked because of where they live or how much melanin's in their skin. And that's really what I'm passionate about as an Indigenous Australian myself. That should be brought in. And I hope to see that happen in the future.